Welcome back. Today we are going to talk about some of the physical changes accompanying aging. Some of the different physical changes that we will see are from functional declines that may be accelerated by disease processes. Now, aging itself is not a disease, it is a natural part of life. However, those different disease processes will sometimes speed up our aging process. So, we will talk about function, including both aging changes in general and common diseases that you'll see. So, some different structures and functions of the eye. There's a picture there that you can see that shows the cornea. That's the outer layer of your eye. The iris, this is like the coloring of your eye. Um, the lens, that is the part that really kind of gets all the information, and then it sends it through the retina um, and back to the optic nerve where your brain can interpret what you see. So, some different signs of vision problems. You may have more trouble with coordination or reach for things inaccurately. So, this is going to definitely have increased safety risks, such as falling or rolling out of bed, or maybe reaching for something and poking themselves with it since they, don't really see it very well. People may squint when they're looking at objects or other people. They may not be able to see your face very well. They might be able to tell that you're standing there, but not be able to tell your facial features. That's why it's important with people with vision problems that we always announce ourselves so that they know who we are in case they can't recognize our face. They may be unable to read print. If you've ever seen those large print books, that's going to help with that. But eventually, some people may not be able to read print at all. That's where we might be able to come in and read a book to them. If they really like to read, they like the information in the book, but maybe they can't read it to themselves anymore, we can kind of step in with that or find a volunteer that can do that if we don't have time. So they might have hesitancy walking because they can't see where they're going. They may not see stains on their clothing. And if you add this to the problem of dementia, they may see the stains, but their brain may not be able to interpret it very well. Or, with vision problems, they may not be able to see how bad the stain is, and then their brain is not going to interpret it as a stain at all. So they may choose odd color combinations in clothing or crafts. So this does not mean that the person is colorblind, but it may mean that they have some visual issues that are affecting the way that they see things. So, some different reasons why we may not be able to see as well when we're getting older is because there's going to be a decreased tear production or drier eyes. This may also lead to reduced ability to focus rapidly, and some other different changes in the eye will also lead to that. There may be decreased sharpness of vision, also called visual acuity. They may react more slowly to darkness and bright and be less tolerant of glare. So you may have people that maybe wake up in the middle of the night and it takes them longer, maybe for their pupils to dilate. And the pupils dilating is what allows more light to be able to get pulled into the eyes. So maybe their pupils don't dilate as well at night and they can't get enough light. And then they're, thinking they're okay and get up and maybe trip over something and fall. So they may have a loss of peripheral vision due to things like glaucoma or central vision due to a disorder called macular degeneration. They may have a change in depth perception. So they may think they're walking towards the bathroom, maybe walking up to the sink, and they think that it's a lot further away than it is, and then they run into the sink. Or they may think they're walking up to the toilet and they think it's a lot closer than it really is. And maybe it's a gentleman that pees on the floor. He doesn't mean to pee on the floor. He thought he was a lot closer to the toilet. So those kind of things may not be because people are doing them intentionally. They may have that change in depth perception that causes them to think that they're a lot closer or further away from objects and have those kind of issues. So they may also have impairment of color vision. So that's where it comes into play with, them mismatching their clothes or not picking the right color for crafts. This can be really problematic, not necessarily for your people in the nursing home, but people that live at home that have these kind of color vision issues, because say they're trying to, do a project or work on something in their home, or they're trying to, say they're trying to jump their car and they can't tell which is the red and which is the black terminal of their battery. That can be a huge issue, big safety issue. I know that's kind of far fetched, but just kind of something to think about. So let's talk about some different disorders. So a cataract is where the lens is covered with a film, and this is going to blur the vision. So you can see in that top picture what's going to happen with your vision with cataracts. Now these will develop, and they take some time to develop. And a lot of times the eye doctors don't want to remove them until they're really bad, because a lot of times cataracts are going to come back. Because chances are, if you have one cataract, get it removed, it's going to come back eventually. So people might be having problems, but it's not quite bad enough to get surgery on it. Macular degeneration, this will blur that central vision. Can be also known as age-related macular degeneration. Unfortunately, for this one, there is no cure. You cannot remove anything to help with, you know, getting that macula restored. People can get eye injections to help slow the progress of the disease, but macular degeneration you cannot cure. Then there's one called glaucoma. I know we've all kind of heard of glaucoma. So this is an increased pressure inside the eye in that vitreous chamber, or the vitreous humor. So there's, naturally occurring pressure within the eye, but the pressure is increased in the eye. And since your eye kind of lays inside the bony socket in your face, there's not a whole lot of room for that. So you have increased pressure in there, but there's nowhere for it to go. So it starts destroying that optic nerve and really kind of damages it. And then you have loss of peripheral vision. So you have something called tunnel vision. So you can see where, in the picture, you can only see the little kids' faces, but you can't see anything around it. That's what glaucoma is going to do to somebody. So glaucoma may mean people are not going to be able to see what's on the side of them. If you've got somebody with glaucoma, don't come up behind them, don't come to the side of them. You need to come directly in front of them, because they may not be able to see you if you're, off to the side. So eventually glaucoma may cause blindness as well. Now glaucoma can be treated by some different medications, but currently there's no cure for it. So you can have some different blood vessel changes as well. These are going to damage the retina. They may be from diabetes or hypertension or high blood pressure. So the damage from diabetes can cause vision loss in different fields. So it just kind of depends on what happens with that. And diabetes can also cause lots and lots of other different changes in the body. That's why we need to keep it under control. But in your eyes, it can definitely damage those small blood vessels. If all of the sugar built up in your system, it might be a little bit bigger than what can go into those teeny tiny blood vessels in the eye, gonna kind of clog them up and cause vision loss. So it's very important for people with diabetes to keep their eyes healthy. So a stroke may also remove part of a field of vision, because remember what a stroke is. The stroke is the bleed or a clot in a brain vessel. And we haven't quite, may not quite have talked about that yet, but we will talk about that during this presentation. But a stroke can definitely affect your eyesight. So with a stroke, you may have one-sided neglect, where the person may not either see one side of their body, or they may not recognize anymore that that side of their body is there. So if you ever see anybody that's had a stroke, and maybe they can still get themselves dressed and they can still maybe comb their hair. Well, if they've had a stroke and the left side of their body is affected, then they may not be able to even tell that the left side of their body is still there. So they might comb the right side of their hair but leave the left side completely alone. Or, smooth out all the clothes on the right side of their body and tuck in their shirt and, tie their shoelaces. Their left side of their body, it's just kind of hanging there because they don't recognize that it's there anymore. So definitely your resident is at increased risk for falling with any kind of vision problems. We've already talked about safety risks, but make sure lighting is a big thing that I think a lot of people don't remember. We go for the obvious, the tripping hazards, the wet floors, making sure the walkers are there, making sure their shoes are tied, their shoes fit. But lighting is another big thing that will go a long way with vision problems. So vision loss may also interfere with the communication. We've already kind of talked about different suggested approaches, writing bigger letters on a whiteboard, making sure that you have people face to face, making sure that you tell them who you are. If you're feeding somebody, making sure you tell them maybe on a clock, where their food is, that the mashed potatoes are at 12 o'clock, the corn is at 6 o'clock, and so forth. So, signs and documents that the resident is to read may be printed with large clear print. So, this is really important if you've got a resident, and this may not be your responsibility, but just for you to know, if you've got a resident that needs some kind of legal document made and they're still cognitive enough to be able to sign for themselves, they can still make that decision, but they can't read the print. So you may have to get some larger print things. And also, again, if people still like to read, but they can't read the small print, maybe try a large print book, and that might be a better alternative for them. So, in the ear is going to also have some changes. The basic structure of the ear, you have your external ear that actually includes the auditory canal, so your ear canal is included in that external ear. Then you have the tympanic membrane, that's your eardrum, and make sure that you don't stick a Q-tip way down in there and bust that eardrum. That'd be really bad. Then you have some different bones inside the ear, the middle ear, and then a eustachian tube that kind of drains out excess fluid. And sometimes, if you get an ear infection, that eustachian tube can get kind of inflamed and kind of hurt, and then it drains. It drains actually into the back of your throat. So if you've ever kind of noticed that when you've got an earache, that it kind of you get maybe an excess drainage in your throat or kind of a sore throat with it. That may be because of the drainage from the eustachian tube. Then on the inside of your ear, in the inner ear, you've got some other different nerves. You've got your cochlear nerve, and that's the kind of stuff that sends all of the sound vibrations to your brain to interpret it. Because your ear actually, the way that the sound works when it goes from the outside to the inside, goes down your external auditory canal. And keep in mind, if your residents have a whole bunch of wax buildup in their ear, then they're not going to be able to hear as well. They may have perfectly good hearing, but if they've got a whole bunch of junk built up in their ear, that's going to make it a lot harder for them to hear. So kind of keep that in mind. And you may have to, find out your facility policy about cleaning the ear canal for some of your residents, because it may need to be done by a nurse, or maybe the CNA can do it. But anyway, so when the sound happens, it goes from the outside down your external auditory canal to that tympanic membrane to your eardrum. Then it starts to vibrate. Then it goes through all those little bones in the middle ear, and then it starts hitting all the nerves, and all the information travels up those nerves to the brain to be interpreted as sound. So, some different hearing changes, warning signs. The TV and radio volume. I know we all have been around somebody that has to turn the TV up to what I affectionately in my family call the jet plane engine volume. So my stepdad is hard of hearing, so he turns the volume way up on the TV. So we knew when he started turning it up and up and up and up, and you could hear the TV from outside the house, he definitely had some hearing issues and it was time to get it checked out. So people may also speak words louder than necessary because they may not be able to hear themselves talk, and they may not think, if they can't hear themselves talk, they may think, well, is the other person able to hear me talk? Maybe I need to talk a little bit louder so that they can hear me if I can't hear myself talk. So kind of keep that in mind. They may not be trying to yell at you. They may just want to make sure that you can hear them since they can't hear themselves. They may ask for words to be repeated. Now, please try not to get frustrated with this. This may not be an intentional thing. I know some of us, well, all of us, know people with selective hearing that they only hear what they want to hear, and you have to repeat yourself several times because they don't really understand what you're talking about because they haven't been listening. But somebody with hearing changes or hearing loss may be listening, they just can't hear you very well. Or they can hear you, but they can't understand what you're saying. So you may have to repeat stuff. And just remember, this is different than having to repeat things with like Alzheimer's, which, you see over and over and over that a person with Alzheimer's will keep asking you the same questions, while somebody with hearing loss may be asking you those questions because if they could hear you properly, they'd be able to understand, whereas somebody with dementia can hear you just fine most of the time, but their brain can't interpret it. So just kind of keep that in mind. Their verbal responses may not match the questions. So if you ask somebody, "Okay, you ready to go down to dinner?" They might say, "Well, what time is it? What time is dinner going to be?" That's not the question you asked. You asked if they were ready to go down to dinner. If you say, "Oh, well, it's time for dinner. Do you want to go?" "Well, what time is dinner going to be?" "It's right now." So you may start thinking that that person is having signs of dementia, where really they may have heard the word dinner out of that conversation, but they may not understand that it's time to go to dinner, or they may have heard time dinner, so they may have thought something differently and needed clarification. So just kind of keep that in mind as well. They may not react to sound out of the visual field. So this is where I kind of go back to my people with scooters that I think are very, very unsafe in any kind of residential setting. So think about somebody with a hearing problem and they're walking down the hall, they're doing just fine. Maybe they're walking down the middle of the hall, no problems, because usually the staff is nice and kind of walks around them. Somebody comes up behind them with a scooter and is not paying attention. That person with the hearing loss may not be able to hear that scooter. And that's a very, very dangerous situation. Because think about if the person with the scooter has the depth perception problem and they're rolling up on your hearing impaired person. The hearing impaired person can't hear them to get out of the way, and the person with the depth perception problem thinks that they have more time. It's a recipe for disaster. But we'll get off the scooter subject. Just know that some of your hearing impaired residents may not react to sounds out of their visual field. So they may also be irritable in situations where good hearing is necessary. Think about your folks that like to go to church. They've gone to church every Sunday their whole life. They really enjoy going to church. They really like to hear the sermons and then talk about it afterwards. And they always come back from church every Sunday and talk to you about, well, the pastor had an amazing sermon today. It was so great. I'm really glad I got to go. So think about those people if they start having hearing loss. How frustrated are they going to get when they go to church and they can't hear the pastor? That's going to be extremely frustrating for them. So we may have to kind of find ways to help them out with it and maybe find some different resources like magnifying headphones or something like that. You can kind of talk to the social worker, talk to the charge nurse, talk to the therapy department, see if there's anybody that has some kind of resource like that. Or maybe even talk to the family and say, "Hey, does the church have these, magnifying headphones, or can you guys start sitting closer to the front?" Because the person, your resident may not say anything to their family. They may be embarrassed and they're frustrated. So they may not say anything to the family while they're out, but they'll say something to you when they get back. Not necessarily all the time, but just an example. So you may decide the next time that they come pick up your resident for church, tell the family, "Well, you know, he complained about that he couldn't hear, and he was really frustrated that he couldn't hear this pastor this last Sunday, and he really, really wants to listen to the sermon and really enjoys it. Is there any way that you guys can sit closer to the front, or if the pastor or the if the church has some of those sound magnifying headphones or something so that he can hear the sermon better. So that might be some different suggestions to try out with that. So some different changes that will accompany aging with our hearing. You may have a reduced ability to hear, especially high frequency sounds. So, this is especially with those people that have been exposed to loud noises when they're younger. So, there is a reason why your mom always tells you, or always told you when you were growing up, don't stand in front of the speaker at a rock concert. That constant assault of loud and high decibel amounts on your ears, all that vibration going through may start causing damage to your ears that you're not going to find out about until you're older. So you may not be able to hear higher frequency sounds. That's why if you have maybe a child that comes to visit, maybe they have a grandchild or a great grandchild that comes to visit, and you know how little kids sometimes they have what I call the little fairy voice. They like to talk like this, and they just love to see grandma, and they want to go see grandma so bad and talk to grandma. Grandma can't hear them. Grandma has lost a lot of the ability to hear those high frequency sounds or the high pitch sounds. So it's going to be really frustrating for them to try to listen to their grandchild, and they want to. They just can't hear them. So they may also have reduced acuity, so ability to hear clearly. Maybe they can hear the grandchild talking to grandma. They love to talk to grandma and tell the grandma all about preschool and oh, I love my classmates and my teacher is so great. Well, they may hear, just the fact that the child goes to school, or they might misinterpret the fact that they like their classmates and think that they don't like their classmates, or just not be able to clearly understand what's being said. So then there may be also tinnitus. Now, this is the presence of a persistent sound that you interpret in the absence of actual sound. This is what we typically think of as ringing in the ears. So there may be nothing going on. You can be in a completely vacuum sealed room, absolutely no noise except the sound of your own breathing, and you hear ringing in your ears. That's tinnitus. So that can happen a lot with older people, and that can be really difficult when they're trying to listen to somebody interpret what they're saying if they can't hear it over the ringing in their ears. And that can be very frustrating and annoying for a lot of people too if it happens all the time. So if your resident ever complains of any of these issues, definitely talk to your charge nurse. See what you can do for them. You may not be able to do anything personally, but the charge nurse may be able to get the resident's family to make them an appointment to go see a hearing doctor or something to figure out what we can do to help them. So, some other different things that we've already talked about back in Unit 4 with communication for people with hearing loss. Make sure that you sit right in front of people, get eye to eye. They might be able to read your lips or might have to read your lips. You may want to talk a little bit louder, but don't yell at people. Especially, you may feel like you have to yell at people in order for them to hear you, and some people you almost do. But make sure if you're talking in that louder voice that you're still giving a good approach, and that you're not yelling at them in a mean tone. So kind of keep that in mind, because if you are yelling at the person or speaking in a louder voice and someone else walks by and they hear you talking to that resident and your tone of voice doesn't sound very positive, what are they going to think? That other person is probably going to think that you're verbally abusing your resident. So really kind of keep that in mind, that you never know what somebody else is going to interpret like that. Also recognize that hearing impairment may be a safety concern, and we've already kind of hashed that one out. So residents can also undergo some different sensory changes. So they can have impaired sensations of touch and loss of temperature sensitivity, we've kind of already talked about this in previous units about the fact that if you go into a residence room and it's 90 degrees in there and they're perfect. They don't notice, that you're sweating buckets just walking in the room. They don't notice that, it feels dry as the Sahara in there. They're comfortable because they have lost a lot of that temperature sensitivity and are not able to get quite as warm. On the flip side of that, if that person gets confused and gets out in the middle of the night, in the middle of winter, and it's 20 degrees and snowing outside, they may not be able to feel that for a while. So they may develop frostbite a lot more quickly than somebody else that does have good sensory and temperature intact. So some different causes that can go along with these sensory changes. You can have paralysis or like a loss of movement or sensation on one side of the body or anywhere in the body actually for paralysis. You can have that edema or swelling because you're going to have excess fluid between the surface of the skin and the nerve endings. You may also have sensation changes resulting from diabetes. If you've ever heard the term diabetic neuropathy, that is a big issue that happens with diabetic people. So we want to be really, really careful with this because not only will that diabetic neuropathy sometimes cause pins and needles pain for people in their feet and hands all the time, but if somebody with diabetic neuropathy starts getting a sore on the bottom of their foot, say they get bit by a spider or they step on something, they may not be able to feel it until there's a gaping hole in the bottom of their foot. So we really, really want to pay attention and provide that good skincare, especially to our diabetic folks. Everyone, of course, but pay extra special attention to those diabetic people. So, some different actions to prevent injury: anticipate your potentially harmful situations. Keep the door between the resident eating area and the food prep area shut so that the person can't reach out and touch the steam table. Make sure that you pay attention to sharp objects. If you've got somebody that, you shaved their face in the shower, you got a gentleman, you shaved his face in the shower, he may not be able to, use the razor himself because he can't feel his fingertips anymore. Make sure you get rid of that razor when you're done. Because if you leave it in there and the person tries to touch the razor, they may cut their fingers on the razor and they may not be able to feel it. So, some different position changes issues. Your resident may not be able to feel when they need to be repositioned if they have nerve ending damage as well. So you need to anticipate the resident's need to change positions. Now, when you've got somebody up in a wheelchair, we've talked a lot about changing positions while in bed. We do every 2 hours. If you've got somebody up in a wheelchair, they need to change position every 15 to 30 minutes. Now, that sounds like a lot, and there is good reason for that. Because think about it: in bed, you've got all of your body weight distributed pretty evenly over the whole surface of whatever side of your body that you're laying on. If you're laying on your back, if you're laying on your side, if you're laying in that prone position on your stomach, in that Sims position, kind of half on your side, half on your stomach, whatever it is, you've got that distribution of weight over the whole body surface area. In your wheelchair, you have the tailbone, the buttocks, the back of the thighs. That's it. All of your body weight, except for your lower legs, is focused on that area. So those areas are going to break down a lot more quickly. If you've got somebody up in a wheelchair, you definitely need to have a cushion in their wheelchair too. And that should be part of their care plan and something the therapy department will help you out with as well. But you need to make sure that that person is repositioning every 15 to 30 minutes. So if you have, say you have a resident that is able to reposition themselves, but they can't feel when they need to be repositioned, your job may go as far as cueing them. So, say they want to go sit in the dining room and play a game with some other residents. They're up in their wheelchair. They can reposition themselves, but they can't feel when they need to be repositioned. And yeah, you've got a lot of other stuff to do. You've got lots of people to take care of. Maybe after caring for somebody, say you go give somebody a shower. Well, before you go give somebody a shower, remind them, hey, shift your weight a little bit. And they just need to get where, the majority of the weight is off the midpoint of where they've been sitting. So if they're sitting right in the middle and most of the weight is on their tailbone and on their buttocks, then maybe tell them to shift a little bit where they're kind of putting a little bit more weight onto the right buttock or the right hip. So then you go give the shower, get the person all taken care of, come back. Okay, it's time to shift again. They might be able to shift more onto their left hip. So just kind of stuff like that. Now, if you have somebody that can't reposition themselves and can't feel the sensation of when they need to reposition, you may have to put a pillow there and just kind of, help shift them, put the pillow under one side, go do something else, come back, shift them, put the pillow under the other side. So just kind of keep that in mind that people in wheelchairs need to be repositioned pretty frequently. And wherever you're working, just ask the other aides how they do that. Just say, okay, well, how do you reposition people in wheelchairs? How often do you do it? And some of your people may have specific care plan interventions of how often you need to reposition them in the wheelchair. So absolutely pay attention to that. But if they don't, then just ask your other aides and see how that can be accomplished. So this is especially important for residents with paralysis. So if they cannot feel or move anything at all, then they are much, much quicker to break down on their skin. So we want to get that taken care of. Also, check your skin frequently for early signs of damage. Remember, your first sign of a pressure sore or a decubitus ulcer is going to be redness over, mainly over a bony prominence or bony spot that does not go away after 30 minutes of having that weight taken off of it. So if you see somebody that's kind of red on their coccyx, maybe, or red on their tailbone, and you turn them on the side, you go back in 30 minutes and the redness is gone. Great, you have prevented a pressure ulcer. If you go back in 30 minutes and the redness is still there, and especially if you push your finger on it and it does not turn white when you pull your finger off, that's called being blanchable, is when it turns white. But if the area is red and non-blanchable, that's a stage 1 pressure sore, and we got to get that taken care of really, really quickly. I know we've already talked about this in previous units, but it's very, very important to kind of discuss again. So always check your skin frequently for early signs of damage, because if you've already got damage in place, it's going to be a lot harder to prevent further damage from forming. So let's talk about the heart. So, the basic structure and function of the cardiovascular system, we won't go really, really in depth of this, but basically, the heart's job is to pump the blood through your body so that you can drop off oxygen and pick up the waste product of carbon dioxide and start the cycle over again. So the heart's main job is to pump out the blood that contains a lot of oxygen that's come from your lungs. It pumps it out to the body. The body uses it as fuel. Then the cells in your body make waste products like carbon dioxide. Then that goes back to your heart to go back to the lungs, and the exchange happens again where the blood will drop off that carbon dioxide to be breathed out into the air and pick up more oxygen that has just been breathed in. Then it goes back to the heart to start the whole cycle over again. So just remember, basic function of the heart: circulate your blood, get the cells the oxygen, get rid of the carbon dioxide. Some different changes that may accompany aging are going to be the heart is less likely to tolerate increased workload. So think about people that are naturally runners. If they go running every day, or you're pregnant, your heart is going to have an increased workload because your body's going to demand more oxygen from those types of issues, the increased activity and being pregnant, having to pump blood to the baby and to yourself. That's going to increase your heart's workload. So as you get older, your heart is less likely to tolerate that increased workload. And just remember that emotional stress and illness also puts increased workload on your heart. So your blood pressure may be less stable, particularly when the resident changes body positions. That's that orthostatic hypotension that we've talked about. So when you have that orthostatic hypotension, then your resident, if they sit up too quickly from lying down or stand up too quickly from sitting, then their blood pressure may drop and they might pass out. So we want to make sure that a lot of our people, or everybody, that we don't try to get them up too quickly. And just check your care plan to see if they have that orthostatic hypotension listed there. And that will kind of give you a clue that you may need to go just a little bit slower for those people. So your artery walls become less flexible. What this means is normally your arteries are able to expand and contract whenever your heart pumps blood through them. So they kind of work like a balloon a little bit. They get a little wider when your heart pumps the blood through them, and then they narrow back down a little bit whenever the blood is already through that part. So if the artery walls become less flexible and they stiffen, then they're not going to be able to expand like they normally would. So the heart still needs to get everything where it needs to go, so then it's going to work harder to push it on through. So that's going to cause an increase in blood pressure. And your blood pressure is naturally going to rise a little bit as you get older. Of course, we don't want those really, really high blood pressures like the 180 over 90 or anything like that. That's still not normal. But somebody that had growing up and, maybe in their early to mid adulthood had 110 over 60 for years, 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 years. Now it's maybe 130 over 80. That's a natural part of aging, is for your blood pressure to go up just a little bit. But depending on which disease processes is going to make it go up even more. So your blood flow to your brain and other vital organs may be decreased. Your body is designed that if you have poor circulation or you have a circulatory issue, that your heart is going to send blood to your vital organs first. So it's going to send blood to your brain, blood to your lungs, blood to your liver, blood to your stomach. It's maybe going to forget a little bit about your extremities. So maybe less blood flow is going to go to your fingertips and to your toes. So people with poor circulatory function may have colder or kind of bluish fingertips or toes, that cyanosis that we see. So that may come along with aging as well. Then your small blood vessels are more fragile and more easily damaged. Kind of like that diabetic issue with the eyes. Those blood vessels are going to be a lot more fragile, more easily damaged. So having that excess sugar build up in those little blood vessels is going to destroy them and clog them. So kind of keep that in mind as well. So, some different conditions in the blood vessel, you can have what's called arteriosclerosis. This is that hardening of the arteries where your artery walls stiffen, they've lost that elasticity, they've lost the flexibility. It's like you have taken the balloon and put paper mache around it, and now you're still trying to blow it up. Well, the paper mache is going to harden and inhibit that balloon from getting any bigger and from you putting any more air in it. So that's the arteriosclerosis. So then you have the atherosclerosis, which is the fatty plaque deposits that are made inside the arteries. So these will also decrease blood flow to the tissues and can eventually lead to where you don't get any blood flow at all. So if you have the arteriosclerosis or atherosclerosis of the arteries in the extremities, this is what is peripheral vascular disease. So, peripheral vascular disease is where you cannot get any blood flow, especially to your feet and to your legs. But this blood flow can, lack of blood flow can injure the nerves and tissue. If you cannot get any blood flow down to your feet and legs, then eventually that tissue is going to start to die. But your signs for that, you're going to see kind of a bluish or a dusky color in the legs and feet if they're not getting any circulation down there. Now, another thing that might go on along with that, you may have peripheral vascular disease that is in the veins because the arteries are the ones that carry all that oxygen rich blood, carries everything out to the tissues, carries all that oxygen out so that the cells can use it. Well, then where does the carbon dioxide go? Carbon dioxide goes up the veins. The veins will take everything back to the heart to get recirculated. So if you have problems in the veins in your legs and feet, you may be able to get the blood down there. It may not be able to get back up. So then you'll see pooling of the blood and maybe have a reddish or purplish appearance and edema from that swelling because the blood is not able to get back up like it normally would. So you can also see hypertension or high blood pressure. Hypertension is abbreviated HTN. There is no abbreviation HBP, that one does not exist. But hypertension, HTN. This is the increased pressure against the walls of the arteries. So, if you have somebody with that arteriosclerosis, with that atherosclerosis, they're going to have high blood pressure because the heart is having to work that much harder and put that much more pressure on those artery walls to try to push the blood flow through to the rest of the body because the body still needs all of the blood and nutrients that the heart can send it. Just the arteries are making it a lot harder for the job to get done, so then the heart is having to work harder and it increases that pressure. Congestive heart failure. This is a pretty common thing that you're going to see no matter where you are. So, congestive heart failure is where the heart does not pump enough blood to adequately supply the body's needs and cannot keep up with the return flow. So the symptoms are going to result from inadequate oxygen supply to the tissue and retained fluid in the lungs and other body tissues. So you can have congestive heart failure on either side of your heart. Now, in your heart, one of the things that I didn't quite explain, but you can kind of see in the picture on the bottom left there are two sides of your heart, a right side and a left side. Now, the right side pumps the blood from your body to your lungs. So, all of that blood that has the carbon dioxide in it, it's got all that waste product in it, the right side will pump it from your body to your lungs. So, if you have right sided congestive heart failure, then that blood is not going to be able to be pumped properly and it will start backing up into your body. So that's where you see people with edema in their feet, in their hands, in their legs, just different edema in their body tissues. Now, the left side pumps blood from your lungs to your body. So the lungs have done their job. They've gotten rid of the carbon dioxide, picked up more oxygen in the blood. Then you go back to the heart to the left side, and then the left side will pump the oxygen, I call it oxygen happy blood, out to your body to get used again. So if you have left sided congestive heart failure, this is where you can have pulmonary edema or edema in your lungs. So you will actually have blood and fluid back up into your lungs because it's not being able to be pumped properly and the heart cannot keep up with it. So there's some different signs and symptoms with congestive heart failure that you'll see. Definitely see an increased blood pressure. That's usually what leads to the congestive heart failure in the first place. You may see people with edema, depending on which side of their heart is affected. You may hear people that cough a whole lot, and they may cough up a little bit of blood in their sputum. And sputum is the stuff that comes out of their lungs when when you cough and you get something out. That's the sputum. So there may be a little bit of blood in there because all of that fluid is backing up in their lungs with that left sided congestive heart failure. People are going to be really tired a lot of the time with congestive heart failure. They're not going to have nearly as much energy. They're not going to be able to have as much endurance. So, if you have somebody with congestive heart failure that has that goal of walking 300 feet to the dining room 3 times a day for a Walk to Nine program, somebody with congestive heart failure may not be able to keep up with that, and they may have to kind of slow down a little bit. So just kind of keep that in mind. It's not that the resident is trying to not try. So, well, some of them may be, but a lot of the times, somebody with congestive heart failure, they may want to try. Their body will not allow them to do as much as they want to do. So sometimes people with congestive heart failure also will feel a lot better when they are sitting upright in a Fowler's position, or sometimes you may have to do what's called an orthopnic position, ORTHOPNEIC, orthopnic position, where you put a bedside table across the bed. They're sitting in a Fowler's position, and you may put a pillow on top of the bedside table, and the person can lean over that pillow. That may help their congestive heart failure symptoms and help them breathe a little bit easier as well. Now, one thing with the congestive heart failure, especially with that left sided congestive heart failure, you do not want to lay these people completely flat, especially if they're having an exacerbation or a flare up of their congestive heart failure. Because they may be trucking along, they're doing fine. Yeah, they get tired sometimes, they're doing all right with their CHF. Well, today's not a great day. They're having a little bit more fluid than most days. They're a little bit more tired. They're having more symptoms. So, these people, especially on those kind of days, do not lay them flat because they need to sit up to have that lung expansion, especially with the left sided congestive heart failure. And if they're laying flat, they're not going to be able to expand their lungs nearly as well, and it will almost feel like they're drowning in their own fluids. So please, please try not to lay somebody completely flat with congestive heart failure, especially when they're having a flare up. So, a pacemaker. I think most everybody's heard of a pacemaker. But this is a battery powered device that helps the heart to beat regularly and at an appropriate rate. So, we've already kind of talked about the irregularities of the heart rate and rhythm. So, if you have that bradycardia, a lot of times, this will be handy when a pacemaker with a pacemaker. So, what the pacemaker does is if the heart has lost its normal electrical pathway, which the heart has its own electrical pathway, so it's pretty cool. So normally the heart is able to stimulate its own electricity and kind of has its own brain. But if that brain stops functioning in the heart and you've got the bradycardia or sometimes pauses in the heart rate, then a pacemaker comes in because that pacemaker has the little battery in there and it can generate an electrical impulse to keep the heart beating. So it's pretty cool. So, a pacemaker, you may see somebody with almost like a little disc underneath the skin, especially on the left side of their chest. So, just kind of be aware of that. Now, pacemakers really shouldn't be around microwaves a whole lot, and you might see different signs places, careful of pacemakers, microwave in use. And pacemakers may have to be checked over the phone just to make sure that they're working properly. But the pacemakers are really, really good life saving devices for people that have electrical conduction issues in their heart because you have to have that electrical stimulus for the heart to beat. If you think about your car won't start and circulate the fuel for you to drive if the battery's dead. So that's where the pacemaker comes in. It's kind of like a replacement battery for your heart. So the last thing we'll talk about on this slide is a myocardial infarction MI, so know that term, MI or myocardial infarction, layman's terms, it's a heart attack. So, this is where part of that heart muscle is damaged because of insufficient blood supply. A lot of times, this is caused by a clot that blocks a narrowed artery. So, the narrowing of the artery with that atherosclerosis, with that plaque buildup, is called coronary artery disease, because those coronary arteries are the vessels that wrap around the heart to feed the heart all those nice, blood and nutrients that it needs. So sometimes it can also be caused by a spasm. If the heart vessel spasms and completely clamps down, then that can cause a heart attack as well. But most likely a clot, either formed by, a blood clot that's traveled somewhere from somewhere else into the heart, or if you've got the clog because of the atherosclerosis. So, your main symptom that you think of is angina, sometimes pronounced angina, either way, which is chest pain. That's going to be your big symptom. Now, there is a picture after this presentation is completed of men versus women with their chest pain symptoms or their heart attack symptoms, because women do feel differently than men. Now, men are what you think of as the typical heart attack symptoms. You've got the crushing chest pain, shortness of breath. You might feel pain down the left arm. You may feel pain in the back. Women, however, sometimes might feel pain in the jaw. They may feel pain across the right side of their chest. They may feel pain in the back. Some women may never feel any pain. They may just get nauseated. Now, that can be confused with a whole host of other issues. But just know that men and women have different heart attack symptoms, and we'll kind of show you a little bit about that as well. So, treatment can be a cardiac bypass surgery or angioplasty. Now, the treatment, it needs to be done very, very quickly. So, if you have somebody, one of your residents says, I can't breathe, I am having chest pain, that is a drop everything and find the nurse. Or if you work in assisted living or home plus, drop everything and call the nurse if your resident is complaining of chest pain. Now, chest pain may be from multiple different other things. However, that's not your job to determine what's causing the chest pain. Your job is to get the resident to somebody that can determine that. And a lot of times that's getting them to the hospital if the nurse can't figure out for sure, this is not a heart attack. And most of the time, your nurses are going to just err on the side of caution anyway, get them to the hospital. So, at that first onset of chest pain, you really, really need to get the nurse, get some vitals, get them ready to go to the hospital if your nurse says so. So, once they get to the hospital and it is figured out that the person has had a heart attack, they can have a less invasive procedure called angioplasty. So, angioplasty is where they take somebody into a room called the cath lab, and they've got all this really cool x ray equipment so they can see the heart beating. And they put a tube in their groin and snake it up through the arteries into the heart and inject some dye. Now, the dye is going to show up on this x ray equipment and it will show where a blockage is in the heart. So then, through that fancy little tube in the groin that's going all the way up to the heart, they can put in what's called a stent a lot of the times. Now, if the narrowing is still small enough, they can use that stent to help open up the blockage, keep the coronary artery open, and restore the blood flow. That's a really cool thing. However, if the if the artery is too much narrowed for a stent to be placed, then someone may have to get cardiac bypass surgery. Now, this is where they go in, very, very extremely invasive surgery. They have to crack your chest open, actually, cut your breastbone, open up your ribs, and they'll take either a vein or an artery from maybe the backside of your leg and put it as a graft to go around the blockage on your heart. So, this will also help restore blood flow to the potentially damaged area. But these things need to happen whenever somebody gets to the hospital. Now, the thing about a heart attack is if you wait too long with a heart attack, a lot of times, just kind of like in that picture there, the muscle will actually die. Now, this muscle, once it has died, cannot be fixed. You cannot replace that chunk of muscle. You cannot, restore the blood flow to it. It's dead. So, if you ever hear the term time as muscle, that's absolutely true. Chest pain is a priority, it's a medical emergency. Get the interventions in place as soon as you can. So, some different changes that will result from cardiovascular disease. These residents may tire easily or experience shortness of breath, no matter what kind of cardiovascular disease they have. Generally, a pacemaker is not going to make them short of breath. Generally, a pacemaker is actually going to make them less short of breath because their heart's functioning as normally as possible now. But especially that congestive heart failure, and if you're having a heart attack, you're going to be short of air or short of breath, tire easily. We want to try to get good exercise for good cardiovascular function, but if somebody already has poor cardiovascular function, that exercise is going to be even more difficult for them to obtain. That's why we need to take care of our hearts as much as we can before we get to that point. Then that orthostatic or postural hypotension, that dizziness when you're changing positions because your blood pressure is dropping. And remember, if your nurse ever asks you to take orthostatic vitals, that's where you want to take the blood pressure and the pulse, lying, sitting, standing, in that order, because we're trying to catch that blood pressure drop. Then we have that edema or the swelling that will result from poor cardiac function. And you may have to put some different interventions in place, like those nice, lovely TED hose or the compression boots that will kind of squeeze things to help that edema. So the edema, if your heart is not functioning right, you've got that CHF, that blood may not be able to, or the blood and fluids may not be able to get pumped properly back up where they need to be. Those TED hose and the compression boots that squeeze your legs are going to push all of that fluid back up to the kidneys where they can be processed out, and people will pee it out rather than having to worry about the overburden on their heart. So, also, people may have skin that bruises a lot more easily or heals a lot slower. If you have somebody on blood thinner products, this is going to happen a lot more too. So, know your people that are on blood thinners. Yes, we know as CNAs, you are not going to be the one responsible for giving the medications, but it's good to know who's on blood thinners because people on blood thinners, you will not be able to cut their toenails at most facilities, and those people need to use electric razors because having a manual razor or one of the normal typical disposable razors that we think of, if that person cuts or gets cut while they're on blood thinners, it's going to take a lot longer for them to clot and to stop bleeding. So definitely pay attention to who's on blood thinners and who's not. So next we're going to talk about the respiratory system. Now the respiratory system goes along with that cardiovascular system to help get the oxygen in, get the carbon dioxide out. That's the main function of the respiratory system. So some different structures we'll talk about. We won't talk about all of these that are on the slide because there's a lot, but we'll kind of go through a little bit of them. So as you breathe in, air starts through your nose or through your mouth, goes into the back of your throat to the pharynx. Now, at the bottom of the pharynx, kind of on top of the larynx is your voice box, but between the pharynx and the larynx is going to be your epiglottis. Now, we've talked about that epiglottis when we talked about swallowing and when we talked about eating, but that epiglottis normally covers your esophagus or the hole that the food goes down when we swallow. But when we swallow, it flips over and covers your larynx or your trachea and your windpipe. So that's really, really important with that, with the swallowing process, that it works properly. So as we breathe in, we breathe that air through our nose, down through the pharynx, down through the larynx, and into the trachea. That's our windpipe. Then it goes into the lungs to the bronchus, and those are some different tubes that kind of break off in your lungs and get the air a little bit more out into the different parts of the lungs. At the end of the bronchioles, which are the smaller tubes off the bronchus, are the alveoli. Now, the alveoli are the little bitty air sacs, and there's just crazy amounts of air sacs, the alveoli in our lungs. But what these do is these expand and contract every time that you breathe. So every time that you breathe in, it expands. Every time that you breathe out, they contract. Now, those alveoli, that's where that carbon dioxide oxygen exchange takes place. So when your lungs breathe in the oxygen in the air, they get to the alveoli, the oxygen slips into your bloodstream from the alveoli. Carbon dioxide slips out of your bloodstream into the alveoli. Then, when you breathe out, the carbon dioxide goes back out. Now, this is important when we talk about different disease processes and why we kind of, get into that. So, some different respiratory changes that happen when we get older. Our lung tissue becomes less elastic. So, just like our blood vessels do, we can't open the lungs up as much anymore. The chest is less able to expand or stretch while breathing. So, it's going to be harder for some people to maintain their oxygen levels in their blood. We can't breathe as much anymore. Some people may have different changes with their musculoskeletal system and they'll kind of stoop over or hunch over. And that allows for them to not be able to breathe and expand their lungs anymore. And if we have people laying flat on their back, especially those folks with CHF, because remember, they might be filling up with fluid in their lungs. But if we have those people on their back, they're not able to expand their lungs as well any very much either. So that's another reason, besides preventing the pressure or decubitus ulcers and the muscle contractures and the muscle wasting, that we want to get people up and out of bed, is to get their lungs expanded. So keep that in mind. Some of the main diseases that we're going to talk about with lung issues are COPD and pneumonia. Now, COPD, we've probably all heard of COPD, but this is kind of a collection of different diseases. So, this one includes um, asthma, chronic bronchitis, and emphysema. And remember what COPD stands for as well. This is going back to our terminology. COPD is chronic obstructive pulmonary disease. So, when we talk about COPD with being asthma, chronic bronchitis, and emphysema, asthma is just kind of an inflammation of kind of the trachea and the upper part of your respiratory system. Chronic bronchitis is an inflammation of those bronchi, or that split off and go to the different parts of the lungs. So it's a little bit deeper. And emphysema is where all those alveoli, those little air sacs that are at the ends of all the bronchioles and make up a lot of the lung tissue, and kind of the last stop when you get to the lungs, the emphysema is where those air sacs are permanently enlarged. So they can't expand and contract anymore. That means they may not be able to take as much oxygen in, and they may not be able to get as much carbon dioxide back out. So your small air passages within the lungs become obstructed because they're inflamed a lot of the times, or they're, um, having those kind of issues. So this will interfere with our airflow. So our breathing will become difficult, and we will have dyspnea. So we will have that difficulty breathing, a lot of times short of air or short of breath, whatever your facility prefers, and you will have decreased oxygenation. Now, COPD is one of those um, conditions where it may not be a good thing to have your oxygen level over 92%. Because a lot of times with COPD, you may be able to get the oxygen in, but you may not be able to get the carbon dioxide out. Now, the carbon dioxide in your bloodstream is what triggers your brain to breathe. However, if you get to certain levels of carbon dioxide in your blood and it gets too high, then your brain thinks, well, you've already got plenty of carbon dioxide. I don't need to take any more oxygen in to make carbon dioxide. So then what happens? Then your brain is going to tell your lungs, well, you don't need to breathe as much. So I'm going to slow down your breathing. Then you may go into what's called respiratory depression or eventually respiratory failure where you don't breathe at all. So that's why we want to pay attention to that care plan and see what oxygen range the people have to go through. Now, this may be way more information than you ever wanted to know as a CNA, but it's a good kind of theory as to why we may not want to see 95, 96, 97% oxygenation saturation on somebody with COPD. 88 to 92 range is usually pretty good for a lot of these people, but always check your care plan. So, people with COPD a lot of times are also going to be on supplemental oxygen. 2 to 4 liters is usually pretty good for them. If you get on up into the 5 and 6 liter range, that may be getting too much of that oxygen in. Their body's going to exchange it into carbon dioxide. Then they can't get it back out. So then you start that whole cycle over again. The carbon dioxide builds up, triggers the brain, says you don't need to breathe as much, even though the person may be feeling like they're short of breath because they can't get any air in. They've got too much carbon dioxide in. Turning that oxygen up all the time may not be a good thing. So the other common condition that we talk about is pneumonia. Now, pneumonia is an infection of the lung tissue that results in that dyspnea or the difficulty breathing. Pneumonia symptoms may include the shortness of breath, low oxygen saturation, so they may have an oxygen saturation of less than 90%. A lot of times they're going to have a fever, because fever is going to be a main sign of infection as well. They may have chills, and they may be coughing up different colored sputum, so something greenish or yellowish, they're coughing up with pneumonia. So this is a really serious infection for somebody if they have pneumonia. Now, one of these causes for the inflammation or for the infection is aspiration of food or vomit. So the aspiration is where that food or vomit gets down into the lungs rather than in the stomach. That's why when we talk about eating and swallowing and that epiglottis, that it's really important that that epiglottis functions properly. Otherwise, you may get the aspiration, and then if you get food or fluids down into the lungs, then it can cause an infection because that stuff's not supposed to be there. So then your body's going to say, hey, you need to go, buddy. And it's going to send all of its forces in to cause an infection that will fight against that foreign substance. And then you're going to get really sick with pneumonia. So, some different common changes in respiratory systems. A lot of times, people will experience being tired a lot more easily and shortness of breath. So, shortness of breath may also be referred to as shortness of air, so kind of keep that in mind. Those residents may have dyspnea. Respiratory rate is usually rapid if they have problems, because if they can't get enough air in, what's your natural inclination if you feel like you can't get enough air in? You're going to speed your breathing up to try to get more of it in. Sometimes with that rapid breathing, it may actually be shallow, or you have such rapid breathing that your lungs don't fully expand and you don't get enough air in anyway. So it's kind of like a vicious cycle with that. So you may have restlessness or anxiety due to the inability to breathe comfortably. Your brain needs oxygen in order to function. So if your brain doesn't have that oxygen going to it, then it's starting to kind of panic, and that will make the rest of your body panic too. Then you also may have that dusky or bluish skin color or the cyanosis due to their inability to breathe effectively and get enough oxygen. So always check the care plan for alterations in care due to respiratory changes. If somebody needs to be in that orthopnic position, if somebody can't lay flat, if they need to have their head abed at 30 degrees or something, or if they need to have supplemental oxygen. So make sure that you alternate short periods of activity and rest. These people a lot of times will, instead of being able to get them up, get them dressed, go to the bathroom, and walk down to the dining room, that may be too much for them. So you may have to start with getting up and going to the bathroom. Maybe help them get dressed while they're in the bathroom. Give them periods of rest. See when they're ready to go down to the dining room because they may need a few minutes, kind of sitting in a wheelchair or hanging out for a minute after they get dressed before they're ready to go down to the dining room. So make sure that you kind of pay attention to how much activity your resident is able to tolerate. So monitor your oxygen administration per your care plan and facility policy. Now, oxygen is one of those things that CNAs cannot change the oxygen level. Only the nurse can. But if your resident is on oxygen and their oxygen is not at the level that is on their care plan, you need to notify the nurse. Now, the facility may allow you to go ahead and change it back to that original care plan level. But if the resident says, well, I'm short of breath, I'm really not getting any air, can you turn my oxygen up? It's at their care plan level. No, you cannot. You cannot turn that oxygen up. That's where the nurse needs to come in and figure out what needs to be done for that person. A lot of times, especially with COPD, when people can't get enough air and they really feel like they're short of breath, my oxygen's not working, I need more, sometimes you can even turn a fan on. And sometimes having that additional air kind of blowing near them will help them feel a little bit better and feel like they are getting enough air in. So, some different oxygen safety measures. We already kind of talked about them in Unit 8 in our safety chapter. Not having any open flames or sparks, wearing cotton clothing instead of nylon, no Vaseline, stuff like that. And then we'll talk about it again in a later unit. So, the endocrine system, we kind of have had talked a little bit about the endocrine system with that diabetes video, but the point of the endocrine system is to kind of balance out all of our hormones and chemicals. So there's different parts of the endocrine system that we'll get into a little bit. So some different changes with the endocrine system. Your body's going to produce lower levels of all of your hormones. So this is going to be like your testosterone, your estrogen, um, hormones like insulin, hormones like glucagon that helps provide blood sugar um, or glucose in your bloodstream, and some other different things. So, some common endocrine conditions, the main one is diabetes. So, we've already kind of really talked about that in the diabetes video, so we'll kind of brush over it a little bit again. So, this is where the pancreas produces an inadequate amount of insulin for the body's needs, and the body cannot use sugars and other food components effectively. So, some different changes that may result: blood sugar levels may be difficult to keep in range. So, people may need a different diet, medications, exercises. Behavioral changes may be a sign that your blood sugar is out of normal range. Remember that your people that are hypoglycemic, that have low blood sugar, are going to be kind of wet and wild. They're going to be shaky. They're going to be sweaty. They're going to be confused. And people that have high blood sugar or hyperglycemia are going to be dry and drowsy. They've been peeing a whole lot. They're thirsty. They are, hard to keep awake. They're really sleepy. So report any of your observations to the nurse, and the nurse may routinely check the blood glucose level. And depending on where you're working, especially if you work at a hospital, you may be taught as a CNA to check blood sugars as well. Just know what your facility policy is, and if you have any questions, just ask. So the different blood vessel changes, this will be where that peripheral neuropathy comes in, or the diabetic neuropathy. They may have nerve damage, slowed tissue healing, so those people with a wound on the bottom of their foot may not be able to feel it. And then it's going to take a lot longer for that wound to heal because they're not getting as good a circulation. If that extremity does not heal, it may be necessary for an amputation or to have the offending extremity cut off. Now, the problem with this is if you have, say, you start out with that sore on the toe, like you see in the picture. And that doesn't heal. Then it kind of travels up the foot. Well, then the doctors decide, okay, we're not going to be able to do anything about your foot. We need to cut your foot off. So they cut the foot off. Then the foot amputation doesn't heal. Then they may decide, okay, we need to cut more of your leg off, get a little bit higher. That part doesn't heal. Then you may have to keep going and amputate more and more and more at the extremity, depending on how bad the circulation is. Now, this is a problem that's not unique to diabetes, but it can be caused by diabetes alone, and diabetes can complicate a lot of other conditions. If you already have that peripheral vascular disease, and then you add in diabetes on top of it, that's just going to compound all of your circulatory issues and going to make your circulation even harder to be effective. So just be aware that your resident may not be able to accurately sense temperature, pressure, or pain. So we've already kind of talked about making sure that those people, that you watch them a little bit more closely, that you definitely reposition them. Make sure that you observe the resident's lower legs and feet and nails while providing personal care. Check for any potential injury or infection, even if it's very small. Ingrown toenails. That's a big thing. People may not think of ingrown toenails, but ingrown toenails can cause problems. And sometimes, if you have an ingrown toenail that is not properly taken care of, that's what can lead to that injury or the wound, like is in that previous picture with the end of the toe that's black. So those ingrown toenails are very, very important on diabetics to get them taken care of right away. And remember, diabetics, you cannot cut their toenails or fingernails as a CNA. Some places may not even let you file their nails. It has to be done by a nurse. It has to be done by an RN. And a lot of times, if people's toenails are that bad and they're diabetic or they have other circulatory issues and the nails are thick and they're not easily cut, then the RN may defer to the podiatrist or the foot doctor to take care of all those nail needs. But absolutely report any issues with skin, feet, nails. Assist the resident to wear their socks with shoes, and check the resident's shoes to make sure that they fit properly and that they have a smooth interior surface. This is especially important again because they can't feel sometimes if their shoes are too tight, if they don't have that good blood flow to their feet, or they don't have good nerve endings anymore. And you always want to make sure that people wear socks or shoes whenever they're up and walking around, even in their room, because if they step on something and injure their foot, they may not be able to feel it. So we always want to keep diabetics' feet protected, even more so than just a regular population. So we've already kind of talked about some other complications from diabetes, like the loss of vision. Diabetes can also impair your kidney function, can cause peripheral vascular disease, or can increase the effects of peripheral vascular disease, and can also cause cardiac problems. Makes people more susceptible to having a heart attack, high blood pressure, strokes, different things like that. So your genitourinary system, this is all the stuff that's contained in your pelvis. So this is all the things below the level of like your intestines, but above your legs, above your hips, or between your hips. So with women, in your genitourinary system, the main functions are going to be your urinary bladder is going to store all of the urine. It's made by the kidneys, stored in the bladder, exits the body through your urethra. Then you're also going to have the labia, and you have the labia majora, which is going to be the outside labia, and the labia minora that are going to be the inside labia. Remember, when you provide pericare, make sure that you open those labia and clean in between. Clean down over that urethra, over the vagina, and on through past the anus. So always, always, always clean between the labia on women and around the labia, between the labia and the inside of the thighs, kind of the groin area. Make sure that you get those clean as well. So for the reproductive part, you have the vagina and the cervix, and then you have the uterus inside. Then at the back, you have the anus. So women are going to have three different holes: one for urine, one for babies, and one for poo. Men are a little bit different. So men still have that urinary bladder with the urine in it. Then they have the urethra, but the urethra serves double duty on a man. The urethra not only is the channel by which the urine exits from the bladder outside of the body through the penis, but also that is where the sperm exit the body. So the sperm are made in the testes, and then they've got that tube that goes from the testes through that prostate, sorry, picks up more fluids, that's the semen, and then out through the urethra. So your urethra in a man is going to serve two functions: urine and sex. And then the anus serves the same function as the woman, which is for the poo. So, some different changes you can have: the kidneys are going to slightly decrease in the filtering capacity. So, you may have a little bit more waste build up in the blood, or you may have a decrease in urinary output from the kidneys. Your bladder is going to be less elastic, so it's going to hold less volume, may not empty completely. So, think of the bladder again kind of like our heart and our blood vessels and our lungs, that they expand and contract, and the bladder may not be able to contract quite as well or expand, but when it contracts, it may not be able to empty completely. So then a little bit of urine is going to be retained in the bladder, and if there's bacteria in that, then that's a nice place, that warm, moist, dark environment for infection to grow. So that's one of the reasons why elderly are going to be more prone to urinary tract infections if they can't get their bladder emptied. Another kind of thing that goes along with that is if you have people that are laying in bed for long periods of time and they don't have gravity working for them to get their bladder emptied as well. If they're laying on their back or on their side and all of that urine just kind of pooling in the bladder and not getting out, then it's a good environment for that infection to grow. So the sphincter, these are the muscles at the openings. So you have a sphincter from the bladder to the urethra, and then you have a sphincter around your anus as well. Your anus is a sphincter, so that's at the end of your colon and your rectum. So these sphincter muscles may loosen. You have less control over voiding and also less control over defecating or having a BM. So that's where you have the incontinence issues coming in. Now, you can do some different exercises. You can do some bladder strengthening or some sphincter strengthening exercises, kind of those Kegel muscles. If you've ever kind of heard about the Kegel exercises where you squeeze all of those muscles, that's going to help a lot with bladder and um, defecation training as well. So, women have a decrease in hormones and a complete shutoff of their hormones with menopause. So, all of the estrogen, progesterone that's produced by the women throughout the lifetime, this will help kind of with all of the lubrication for the vagina and help with the urethral lining as well. And when you have menopause, when that estrogen goes away, then you may not have as much thickness of the walls, and the walls will become less elastic and thinner, and it may also make it more painful for women to urinate if they don't have as much estrogen that they need to have in the urethra as well. The man can have the prostate gland enlarged. Now remember that urethra goes from the bladder through the prostate and then down and out the penis. So if you have that prostate gland that's enlarging, that's going to start affecting the urethra as well, and it might kind of constrict it a little bit. This is where you're going to see a lot of men that will kind of dribble their urine or complain that they need to go all the time, but they can't get very much out. And they're having all sorts of issues like that. So people with prostate enlargement may have more urinary frequency, more urinary urge, and less, output at a time. And that's going to be very frustrating for those men. So we need to be patient with them because they may feel like they need to go all the time, but they've only got just a little bit coming out because their prostate is kind of clamping down on it. So, some different genital urinary conditions that we want to take care of. You can have vaginal inflammation and bladder infections. So, these are kind of common in women a lot more often, but bladder infections can be common in men as well. You want to report any urine or vaginal drainage that has a foul smell. Also, with the urine, especially, you want to report any cloudy urine, any dark urine, concentrated, if it has white stuff floating in it or any blood. Report all those things immediately because someone could have a UTI or a urinary tract infection, or they need a UA or urinalysis to rule out a urinary tract infection. So, also, if your resident reports any irritation, burning, itching, or requests a toilet more frequently than usual, let your nurse know. Pay attention if people start tugging on their clothes in that area, if they start tugging on their pants or scratching, then that may indicate either a UTI or maybe even a yeast infection. So, some sexually transmitted diseases, these should be absolutely reported to the nurse right away as well. And just keep in mind that these can still happen in a long term care facility. So, you want to report any drainage from the vagina or penis, any, you know, discoloration in the skin in that area, any bumps, anything like that that may be going on. One other thing is a prolapsed bladder or uterus. So, this is caused by weakened support muscles that will allow the uterus or bladder to sag downward, possibly protruding from the vaginal opening. So, you may see kind of some muscles coming out. So, you want to report any presence of prolapse, so anything kind of hanging out of the vagina that you don't normally see, or a protrusion that looks like muscles coming out of the vagina. So the person may need a sling or a pessary inserted, and the pessary is kind of like a cone. It's a weighted cone that naturally uses the vaginal muscles to get held in there. So that pessary may be used to strengthen the vaginal muscles and strengthen that wall back up. Then the person may not also need surgery and get a sling put in to where the sling will hold up the bladder if it's protruding into the vagina. So, BPH, this is a condition that is exclusive to men. This is an enlarged prostate that is present without cancer or infection. So, the prostate tissue may press on the urethra and interfere with urination. But cancer of the prostate may also have similar symptoms, so that's why it's important to get it checked out by a doctor and get that figured out. So, any observations you need to report, any straining while urinating, dribbling, or small or weak stream. If people complain of needing to go a whole lot and they don't do a whole bunch, and they say, well, I've gone to the bathroom and I still feel full, I still feel like I need to go, but I can't go. Those are all signs of BPH or prostate cancer that need to be taken care of right away. The musculoskeletal system. Now, the musculoskeletal system, the main function of that is to move our bones and muscles where they need to go. We use bones and muscles for everything. We use bones and muscles for eating, for talking, for walking, for pointing our fingers or clicking the mouse on this program, or doing any basic function. Breathing, we have to use muscles for. So that's the kind of the basic function of the musculoskeletal system. And we won't get too into which muscles are which and which bones are which. We don't need to know all that, but just kind of know the bones are the framework of the body. So without our bones, we'd just be kind of a gelatinous mass and we wouldn't be able to move anywhere. Well, without the muscles, we wouldn't be able to move our bones. So they go hand in hand, and it's very important to keep both of them healthy. So, some different musculoskeletal changes that will happen. The bones are going to become thinner and more brittle as minerals are lost or unable to be retained as well. Your joints will lose flexibility, so you will not be able to squat down as well as you could. May not be able to make your hand into a fist as well as you could. The muscle fibers are also lost, and your muscles will weaken. So this is another reason why people may fall a lot more if they don't have as good muscle tone and they don't have as good of muscle function anymore. So some different diseases or conditions that will happen as you get older. Osteoporosis. This is a big one. Osteoporosis. This is a result of mineral loss from bones, and your bones are going to break a lot more easily. So, a lot of times when you hear of someone breaking a hip, if they have osteoporosis, a lot of time it's not that the person fell and broke their hip as a result of the fall. It's that their hip broke and they fell as a result of the break. So that can happen quite commonly with osteoporosis. And if that happens, that's when it's very, very important to make sure that you get a good statement from your resident if they fall and break something that, a lot of times people will be walking, they'll be walking along just fine, and their leg will spontaneously fracture because of osteoporosis. If their bones are that brittle and weak, then they'll fall. That's where it's really, really important to get a good story from your resident, especially if they're an accurate historian. They know what they're talking about, so that you can kind of help support the story of, okay, this fracture is a result of osteoporosis. It's not a result of something that the staff did. I know I'm getting way back on the reporting chapter, but it all kind of ties together. So, when your bones of your spine are affected with osteoporosis, the person's height decreases and the posture will become more stooped. Again, you can have spontaneous fractures in the back as well, and these are usually called compression fractures. So, this is where basically the weight of the spine and the brittleness of the bones will cause the spinal bones to break. And people can go in and get surgery to get those easily corrected. But you may hear of people, especially with compression fractures, people are going to hurt a lot more when they're sitting than they are standing, because all of that weight and the pressure is coming down on their back rather than being spread out throughout their entire body. So your posture changes will contribute to poor balance. This is where people are stooping over, they may be looking down more, they're not looking up. They may be trying to compensate for that, or they may be weak, on one side more than the other too, and it'll be leading to poor balance and just a bad idea overall and increased risks of falls. So fractures, these are broken bones, and a fracture is a break. It used to be said that, oh, well, you just have a fracture. It's not really a break. Yes, a fracture is a break. So your broken bones are going to be more likely because of your osteoporosis, poor balance, and impaired vision. A lot of common sites include the hip, the wrist, and then those compression fractures of the spine. Those are pretty common sites to see fractures in older adults. Another really big term that you need to know is osteoarthritis. Now, osteoarthritis is damage to the joints resulting from normal wear and tear. Now, the osteoarthritis you're going to see a lot more in your weight bearing joints. You're going to see it a lot in your knees and your hips. This is where the cartilage between the bones starts to wear down and starts to get destroyed. And eventually you will have bone rubbing on bone. That's why you have people that kind of have that creaking or grinding when they move, especially their knees and their hips. And this is going to be a lot more prevalent in people that have had manual labor jobs throughout their life. So people like carpenters, construction workers, if they played a lot of sports, impact sports like football or wrestling or something like that. So your joint surface is going to be damaged, and then a bony tissue will grow in that area. and kind of make it a little bit more painful for those people. Your joint flexibility will also be affected, so people may not be able to straighten their joints or bend their joints as much as they used to be able to. One of the other things that goes along with our musculoskeletal conditions is amputation. So this is surgical removal of part or all of an extremity. So this may be due to blood vessel complications of arteriosclerosis, diabetes, poor healing, or it can be due to infection. So if you get a wound and it's not treated properly, or if it is treated properly, but you still have a resulting infection, eventually that infection might be able to get into your bones. And if that infection in your bones is not treated properly or can't be treated properly, then you may have to have an amputation as a result. So, some different ways that we can help residents with musculoskeletal conditions. We want to follow all of our safety measures to prevent falls and to prevent injury to the feet and toes. So, we want to use that gait belt, use the walker, use the lifts if we have to, make sure that we watch people's feet in their lifts, make sure that we assist with mobility, get people up in the wheelchairs. All these things with providing exercise to those weight bearing joints, especially like ambulation or mobility, these are things that are going to also help prevent osteoporosis in addition to helping keep the muscles going. So, we always want to encourage resident participation, give them as much control as possible, and boost their confidence. Then we want to help our resident eat a nutritious diet. This is really important as well because a lot of your vitamins and minerals that are in our nutritious diets are going to help supplement maybe some of the vitamins and minerals that their body has not had or can't keep to help build their bones and keep strong muscles. So let's talk about the nervous system. Now, the whole point of the nervous system is that it is the way that the body sends and receives messages. So, the central nervous system is comprised of the brain and the spinal cord. Now, the brain is the control center of your whole body functions, everything that you do in your body functions. The brain is the control of it. So, say the brain decides, I want to make somebody walk. So, the impulse gets started in the brain, travels down the spinal cord, then it goes to the peripheral nervous system and all to all those other nerves, and the nerves will tell the muscles, "Okay, I want you to walk." That's how it kind of happens. Now, the data or the information can go from the brain out to the body, but then it can also go from the body back to the brain. So, let's think about somebody that walks up to a hot stove. Now, your brain may tell the hand, I want you to reach out and hover your hand over the stove to see if it's hot. So you reach out your hand, then your hand, the nerve endings in your hand interpret, okay, it's hot. I need to pull my hand back. So the heat will travel into your body and send impulses and information from your nerve endings back to your brain and tell your brain that's really hot, then your brain will send another impulse back to your hand and say, pull back. This is all going to happen as an instinctive reflex before you even realize what's happening. But the reason why I talk about it will become apparent and why it's different in older people. So, some different nervous system changes that happen. Just keep in mind that the aging changes in the nervous system are not the same in all people, nor do they occur at the same age. So you may have somebody that has, say, you have someone with a stroke or MS. They may start showing symptoms at a much earlier age than somebody else, and that's okay. We're all different. So, confusion is not a natural consequence of aging. Please keep that in mind. A lot of people used to think, oh, well, they're just senile, they're confused, it's normal, they're old. No, that's not a normal part of aging. Confusion is not a normal part of aging, and it may be part of a disease process. Yes, people may get a little bit more forgetful as they get older. That's natural, but being chronically confused, not knowing what's going on, and having a progressive loss of memory may indicate dementia. We'll talk more in depth about dementia in another unit, but just kind of keep that in mind. Some of our nerve cells are lost and they cannot be regenerated. Some of our nervous system impulses will transmit messages more slowly, and the reflexes are slowed. So that's why I talk about the hot stove. So, say your brain has told your hand, okay, put your hand down. It may not be trying to test to see if the stove is hot. You may just be standing next to the stove and you get kind of tired, you want to lean on something. So you put your hand down. And it might take longer for that message to get relayed from your hand back to your brain, and then from your brain back to your hand saying, the stove is hot, you need to pull your hand off. It may be too late and damage may have already be done at that point. That's why we really have to pay attention to keeping our elderly folks safe, because they're going to have slower nerve impulses and our reflexes are going to be slower. So let's talk about some different conditions. Parkinson's disease. Now, Parkinson's disease is a pretty common one that you'll see. So, Parkinson's disease or Parkinsonianism, and that may be the Parkinsonianism may be caused by different drugs, but the Parkinson's disease is something that happens in the body itself. So, Parkinson's disease is a progressive destruction of the brain area that controls smoothness and purposefulness of our muscle movement. So, our muscles may become rigid, our posture becomes stiff and stooped. These people are the people that also, if you see a little bit further down, that have shaking or tremors. So people may be sitting in a chair and they're just shaking. They have tremors. Sometimes it's more pronounced when they try to reach for something, but they're just sitting there shaking all the time and they cannot control it. So your resident may also have a shuffling gait, slow and shuffled gait. They can't pick their feet up. So if you have a tripping hazard in the way, if you've got a cord down, or you've got a frayed piece of carpet, or you have an area rug down, normally people will see that and their brain will say, okay, that's a trip hazard, pick your feet up. Well, people with Parkinson's may not be able to pick their feet up. They may kind of shuffle their feet along the ground and not be able to have that foot clearance, and it's going to provide a much higher tripping hazard for those people. So, your residents may also easily lose their balance. So, they're going to be much higher risk to fall, not only from that slowed shuffle gait, but from the balance issue as well. And the resident may have difficulty changing positions, getting up from a chair because of their muscle stiffness. Another thing is the resident may have difficulty swallowing. So they are at higher risk for aspiration and aspiration pneumonia with Parkinson's. Then they might also have issues of fatigue. So fatigue and stress can intensify the symptoms of Parkinson's. So we really want to keep our Parkinson's folks, yes, we want to keep them moving as much as we can because we don't want them to have those other complications of immobility like the osteoporosis, like the decubitus ulcers, like that muscle weakening. But we want to make sure to give them plenty of rest periods as well so that their symptoms don't intensify. The next disease we'll talk about is multiple sclerosis, MS. This one is a progressive destruction of the insulation covering the nerves that will result in a loss of muscle function. And the symptoms will depend on the specific areas of the brain or the spinal cord affected. And you may have different symptoms different days. So you kind of don't know what to expect a lot with MS, depending on the person. Some people may have consistent symptoms from day to day. Some people may have different symptoms. So, one of the symptoms you can have weakness or paralysis of the extremities and muscle spasms. Now, the muscle spasms may look similar to Parkinson's. They may have tremors. They may have kind of spasticity issues where they try to reach out for a cup on the table, and maybe when they're sitting, they don't have any tremors or spasms, but they try to reach out and their hand starts shaking and they can't reach that cup very well. This is going to make it harder for people with MS to eat. So these people may need that adaptive equipment, the modified silverware, the weighted gloves, things like that. So they may have blurred vision or other vision problems, definitely decreased coordination, and eventually people with MS are not going to be able to walk. People with Parkinson's may be able to walk a lot longer than people with MS, but people with MS are going to have that decreased coordination, the muscle spasms, and weakness and paralysis, and they're eventually not going to be able to walk and be confined to a wheelchair. Again, fatigue or stress can often intensify these symptoms as well. So we want to keep people with MS going as much as we can, encourage their independence, but also give them plenty of rest periods so that their symptoms don't intensify. So ALS, this is amyotrophic lateral sclerosis. You may have heard of it as Lou Gehrig's disease. Now, this is a progressive destruction of the nerves that send messages to the muscles. So your brain may be working. It may be saying, hey, I want to reach out for that cup on the table, or I want to walk, but your body may not ever receive those messages because the nerves are destroyed. So this may result in weakness, loss of coordination of muscles, and muscle spasms, and will interfere with the resident's ability to care for themselves and to perform their ADLs. This kind of starts sometimes from the outside in. So it may start with the feet or the hands, then it's going to move up the legs, up the arms, and eventually it will affect the way people swallow and breathe. And this may happen early in the course of the disease. So somebody diagnosed with ALS may not have but a few years to live after their disease is diagnosed. Epilepsy. This is seizure disorder. This is an electrical malfunction in the brain that results in seizures or convulsions. So this is kind of the brain, will fire a message and it goes from one cell to the next to the next to the next. Well, with epilepsy, that may be going completely haywire. So people with epilepsy, if you think of epilepsy, you kind of think of the grand mal seizures. So the big seizures where people are, all of their muscles are shaking, they're having the big tremors, they're not able to talk to you, you can't really stop the tremors. That's a big grand mal seizure. There's many, many, many different types of seizures, down to absent seizures where people may just kind of stare off into space. They may not be trying to ignore you or getting kind of spacey or just not paying attention. They may be having an absent seizure. So, kind of pay attention to that and look at your care plan to see who may be having those absent seizures and who's just looking out into space. So, people with epilepsy, what you want to do, you absolutely, if somebody's starting to have a seizure, get them down on the ground, or if they're in their bed, you can leave them in their bed. Get a pillow under their head and get the nurse. Do not stick anything in their mouth. We used to teach that you could stick a spoon in their mouth or a wallet or a tongue depressor. Very, very dangerous because people would think, oh, they're going to swallow their own tongue. It's pretty much physically impossible to swallow your own tongue. Yes, your tongue may drop back and block your airway temporarily, but once the seizure is over, then your tongue will go back to its natural position. And when people are done with seizures, we roll them over onto their side into a recovery position, and their tongue will drop and open their airway again. But the reason why it's very dangerous to stick something in somebody's mouth, they may bite it off. They may bite the tongue depressor off and they may swallow the tongue depressor. If you stick a spoon in somebody's mouth, they may crack their teeth. So don't stick anything in anybody's mouth. Yes, they may bite their tongue, and that's what we're trying to avoid, but biting their tongue and having that heal is probably a lot better than having cracked teeth from a spoon or swallowing a tongue depressor and having to get that out. So get people down on the ground, put a pillow under their head so they don't hit their head on the floor, and get the nurse. That is your duty when somebody is having a seizure. So the next thing we'll talk about is a stroke. This, unfortunately, is a rather common thing in the elderly. So a stroke is a loss of blood supply to part of the brain that causes a sudden death of the brain tissue. Now, a stroke can be caused by either a bleed or a clot. So, either way, you have the blood flow that normally gets through. Think about traffic. I know we kind of talked about traffic before, but think about traffic. If you get congested traffic and you're stuck, you can't get to where you need to go. Maybe you are supposed to go to work and provide services to somebody, and your coworker is counting on you getting there on time. Well, if you're stuck in traffic and you can't get anywhere, that coworker is going to get frustrated. Then they're going to get angry, and if, maybe your cell phone's dead, you can't call them. Well, then they're going to start getting really, really mad, and they're not going to like you anymore. That's kind of what happens with a stroke. Is that brain tissue is deprived of blood and oxygen for whatever reason. You get stuck in traffic, that's kind of like a clot. Maybe there's a detour and it takes forever, and then you can't ever get to your destination. That's like a bleed, where all that blood is leaking out into the tissues, but not where it needs to go. So that's what a stroke is. So the location of the brain damage will dictate the kind of loss that the function results in. So, examples of possible function loss, you can have hemiplegia, which is paralysis that affects one side of the body. And keep in mind that if it happens on the right side of the brain, it affects the left side of the body. At the base of our brain, our spinal cord comes out and it actually crosses. So, what happens on the right side of the brain affects the left side of the body. Left side of the brain affects the right side of the body. You may have spasms and lost sensation. You may have speech impairment, swallowing impairment, perceptual deficits, or the loss of the ability to sense that body positioning up from down, right from left. So people may be walking into stuff all the time if they can walk. That's where you have that unilateral neglect, where they may not recognize that they need to groom one part of their body because they may not know that it's there still. You may have personality or mood changes. You may see people that were as sweet as could be before that they had a stroke, and now they're angry all the time. They yell at you, they cuss at you. Well, there's a part of their brain that's been damaged. That may not be because of that person's personality. It may be damage as a result of the stroke. So much of your recovery is going to occur within the first days and weeks following the CVA or stroke, but it could continue for months. And sometimes it can even continue for years. So, early medical treatment and restorative care are vital, absolutely vital. Now, after this presentation is over, there is a little video about the symptoms of stroke, but I do want to talk about them now. So, the symptoms of stroke that you need to pay attention to, there's an acronym called FAST, FAST. This stands for face, arm, speech, and time. You may have facial drooping. So, if you suspect somebody is having a stroke, you might try to get them to talk to you or smile. If both sides of their face don't go up when they smile, or you see one side of their face is drooping, that's indicative of a stroke. Could be other things, but it's definitely indicative of a stroke. Arm, A. So you may have one side of the body that's weak or paralyzed. So this is where the nurse may have the resident grip both of their hands. So if you see somebody saying, okay, squeeze my hands, they're checking to see if the person is weak on one side of the body versus the other. If they are significantly weaker on one side, that's another sign of a stroke. S stands for speech. Have them talk to you. See if their words are slurred. See if they even make sense. Some people with a stroke may have aphasia. APHASIA. Aphasia, where they can't speak at all. Or they may have dysphagia. DYSPHASIA. Now keep in mind that dysphagia is different than the swallowing one. Swallowing is spelled dysphagia with a G. Speech is spelled dysphagia with an S. So people may have dysphagia or difficulty speaking, or aphasia and complete lack of speaking if they're having a stroke. So our last one is time. The time is important. It's not a symptom necessarily, but it is important to round out what you need to do or how you need to tell if somebody's having a stroke. So the time means you need to know when the person was normal last, when they weren't having stroke symptoms. You may not know, but if you do, say it's 2 o'clock, you're finishing up your shift, you go in to check on Mrs. Jones, you think she's having a stroke. You had seen her at 1 o'clock and she was fine. That is vital information because you generally have 3 to 4 hours to get somebody to a hospital, get diagnosed with a stroke, and if it's a clot that's causing the stroke, they can give medication to bust up the clot and restore blood flow. After that 3 to 4 hour time period, that brain tissue is permanently dead. So it's very, very vital to know when the person was normal last or how long the stroke symptoms have been happening. So we have another condition where the symptoms will last less than a day, and that's called a transient ischemic attack or a TIA. However, this does not mean somebody's out of the woods if they have a TIA. People that have TIAs and that start having more TIAs, these are warnings for a future stroke or CVA. So you will hear somebody say, "Oh well, yeah, we thought mom was having a stroke, but it was just a mini stroke. It was a TIA." Well, that's not just anything. That's still a warning for a future stroke. And the more you have of those, the higher incidence or likelihood it is that you're going to have a full-blown CVA. So kind of keep that in mind as well. So we can have people with spinal cord injuries. So the damage to the spinal cord will result in paralysis of structures below the site of damage. Now, the spinal cord, just like the brain, cannot regenerate. If the spinal cord is damaged but is not completely damaged, so say it's bruised or it's injured but it's not severed or it's not had a complete lack of blood flow, sometimes those symptoms will resolve themselves with time, and you can give medications to help that as well. However, if you do have that complete involvement, the severing of the spinal cord or a complete lack of blood flow where the cells have completely died, you're not going to get that function back. So sensation may be lost. So the loss of the function is going to depend on where you have the spinal cord damage. So you can have paraplegia, and this is paralysis of the lower body and extremities. We typically think of everything below the waist with paraplegia. You could have quadriplegia. So this is paralysis of the torso and all four extremities. This is somebody that can't move anything at all. So they can maybe move their head and their neck. They may not be able to breathe on their own, but they can't move any of their arms and legs. So specific losses of function will shape the scope of our restorative care and will be the basis of our care plan. All body systems are usually affected when you've had some kind of spinal cord injury. It just, where the spinal cord injury will determine where the injury is will determine where it's going to be affected. So the higher the spinal cord injury or the higher the area in the spinal cord for the injury, the more loss of function you're going to have because that spinal cord injury the spinal cord works from the top down. So if you have an injury at the lower part of the spinal cord and the upper part of the spinal cord is still getting blood flow and nutrients and everything that it needs, then just the lower part of your body is going to be affected. Anything that offshoots from that spinal cord at that level. But if you have damage to the upper part of the spinal cord, unless it's something just really super unique, generally you're going to have damage from that level down. So if you have damage at the nipple line part of your spinal cord, then you're going to have damage or loss of function from the nipple line down. And you're not going to have any of that function be able to be restored at the lower part of your spinal cord. So then our last neurological thing we're going to talk about is dementia. Now, dementia we're going to go into a lot more in depth in a later unit, so I won't talk a whole lot about it now, but I know we've been talking about it throughout the course, and it's really important because dementia is a very, very common thing to see in care facilities and even out in the public with the elderly, and it's getting more and more common. So, dementia is a progressive loss of brain function. It involves your memory, your learning, your judgment, cognitive skills, and communication. So, some other body systems are involved in the dementia process as well as the dementia progresses. And eventually, the dementia will start with your memory, but it will start inhibiting all of your physical functions as well the later it gets. So, the dementia is kind of an umbrella term. Kind of like that COPD was an umbrella term for all the different lung diseases, the dementia is the umbrella term in this one. So, this is different neurological conditions that are going on. So, if you've heard of the most common one, Alzheimer's disease. Alzheimer's disease is a type of dementia, and it's characterized by the way that it moves through the brain. So, Alzheimer's disease is a type of dementia. And dementia with Lewy bodies, this is another different type of dementia. And we'll get more into that whenever we talk about the dementia chapter itself. Then you can also have multi infarct or small stroke dementia. So, all those little strokes can be leading to dementia symptoms as well. So, the difference between dementia and delirium is that dementia is a reversible loss of brain function. Dementia is a progressive and irreversible loss of that brain function, but delirium is reversible, so it can get better. So, this is usually the result of a treatable condition such as an infection, medications, or dehydration, and has a sudden onset. Dementia has kind of a slower onset. We're going to see dementia symptoms typically at least a few years before somebody's even diagnosed. And it may be that forgetfulness that's kind of, thought of as more common as getting older. Then maybe the confusion. Well, then that confusion doesn't go away and it gets worse and it keeps getting worse and more confusion. That's the pattern of dementia. But delirium, somebody may be fine one day, out of their mind the next. They're confused, they're forgetful, they don't know what's going on. That's delirium. And the hard part is when you have somebody with dementia that maybe lives at a facility, say they live there for 2, 3 years, something happens, they end up in the hospital. You can have hospital induced delirium because people don't know where they're at. They get confused, they get scared. This is where a lot of your dementia folks will be in the hospital and end up in restraints. Because the hospital is like, I gotta figure out how to take care of this person somehow. They're combative, they're trying to hit me, they're trying to kick me, they don't know what's going on, they're not safe, they're trying to crawl out of bed. So this is why a lot of times people will end up in restraints in the hospital is they have that hospital induced delirium. And sometimes it'll take them a little bit longer when they get back to your facility to get back to that familiar environment. So kind of keep that in mind if you've got people, especially with dementia, that end up going to the hospital, and when they come back, it's going to take them a little bit to get back into their routine. So let's talk about skin. So your skin provides a few different functions. Keeps the germs out and provides a barrier, keeps the moisture in, and it also provides our identity and provides various other functions with, you know, sweat glands and different oils and things like that. But mainly to keep the germs out, keep the moisture in, and provide our identity. So as we age, the skin is a lot thinner. So you see in that picture how you've got that epidermis and then the dermis and then that fatty tissue underneath. So we have that loss of subcutaneous fat and our skin is a lot drier. There's less oils being secreted from our skin. It's also less elastic and less resilient when subject to stressors. That's why it's a lot easier for somebody that's older to get a skin tear or pressure sore. So our healing may be slowed because of decreased peripheral circulation and also because of that decreased fat pad. Sometimes our nails are often more brittle and maybe thicker. Our hair is often thinner and less oily. And kind of going back to the ears and goes along with the skin, our earwax gets a lot thicker and drier, so it's harder to get out. So kind of keep that in mind as well. So, one of the things that we're going to talk about, a condition that sometimes happens in older adults, is cancer. So, cancer is an uncontrolled growth of abnormal cells that produces tumors. Now, our tumors can be benign or malignant. The benign tumors are going to be non cancerous and they do not spread. The malignant tumors are going to be cancerous and they will spread or metastasize to almost any body tissue. So, sometimes the way people will find out that they have cancer is that they maybe go in because they're having trouble breathing. So, the doctor does a scan, they find that the person has cancer in their lungs. They may take a biopsy or a sample and figure out, okay, this is not the normal lung cancer. Where is this coming from? So it may have spread from another part of the body by the time you find out. So your symptoms are going to depend on where that tumor is growing, and it's going to press on healthy tissue and interfere with its function. So, some different common cancer locations: lung and colon cancers will occur in both men and women, and men have specific to the prostate cancer, and women, a common site is breast cancer. Men can get breast cancer as well, but of course it's most common in women. So, some different methods of removal or management of the cancer: you can have surgery to remove the tumor or treatment with radiation and medications called chemotherapy. And your resident may be staying at your adult care home to get better and recover their strength back. Then you can choose to do either palliative care or comfort care. So, palliative care means that you're treating the pain symptoms and you're treating all of the symptoms without doing real aggressive treatment. Comfort care means that you have basically stopped any aggressive treatment and you're only focusing on the pain control. Now, the reason why I point this out is because you can be getting that aggressive treatment, getting the radiation, the chemo, and still be on palliative care and get that pain management and the comfort management. But if you go to what's called comfort care, then you're stopping any aggressive treatment at all. And you're at end of life. You are not going to get better, and the focus is more on the quality of your life rather than on the quantity. That's another topic that we'll discuss in a later unit, but just kind of be aware of that. So, some common care needs for residents with cancer: you will definitely want to make sure that you provide nutrition and fluids for people, and be aware that a lot of your cancer treatments are going to make it difficult for people to retain or want to take nutrition and fluids. So, try to be creative. If somebody doesn't want to eat or drink something, sometimes they may need a bland diet, especially if they've had, cancer in their mouth or in their esophagus, and things just may not taste good to them. So you might kind of get with their family or ask the nurses what you can do to help them eat and drink and kind of keep their nutrition and fluids. You may have to do skin care because sometimes radiation can burn the skin. So you may have to provide other skincare. And a lot of times, medications such as radiation and chemo can change the consistency and the acidity of people's urine and stool. So if people are incontinent of stool or BM, then their stool may be very, very caustic and can really be very irritating to their skin. So you need to kind of keep in mind that as well, and make sure that people are comfortable, whether they are fighting the cancer and still trying to get aggressive treatment, or if they've gone on to that comfort care. So, your responsibility for the early detection of cancer, of course, you're not the one that has to figure out if the person has cancer, but you can still report some different changes that might be early signs and warning signs. So, you can report any changes in bowel or bladder habit, any sores that don't heal, any unusual bleeding or discharge, any thickening in the breast or elsewhere if you notice that, any indigestion or difficulty swallowing, any obvious changes in a wart or a mole, because you may be the first person to see that, when you're given showers, or if a person has any nagging coughing or hoarseness, that can be an early sign of cancer. These can all be signs of other different kinds of issues as well, but since they are signs of cancer and the other things, we need to get them reported as soon as possible so that the person can get treatment and get it taken care of. So this concludes our presentation. I know that one was kind of long, but it's really important to kind of talk about the different physical changes accompanying aging. Again, if you have any questions, please notify your instructor, and I hope you have a great day.